If you are working in the pediatric cardiac ICU, there are a lot of things to worry about when taking care of a kid after heart surgery. In this video, I'm going to talk about post-operative pulmonary hypertension. I'll talk about what it is, who's at risk, and what we can do about it. When talking about pulmonary hypertension in the ICU, I'm really talking about two things that are related, but cause different clinical problems. The first is consistently elevated pulmonary artery pressures. The technical definition of pulmonary hypertension is a mean PA pressure greater than 25 millimeters of mercury at rest. We don't talk about that definition as much in the pediatric cardiac ICU as we don't often have direct PA measurements. We may be able to estimate the right ventricular pressure as a surrogate for PA pressure from the velocity of the tricuspid valve regurgitation. Given the wide range of pediatric blood pressure norms, you are more likely to hear us refer to estimated systolic PA pressure compared to systemic blood pressure. So a patient that has half systemic RV pressure is high, but not terrible, and a patient that has systemic or higher RV pressure has a real problem. The muscle in the RV isn't designed to pump against systemic pressures, so it will eventually fail. The second clinical problem we see in the cardiac ICU is pulmonary hypertensive crisis. The baseline pulmonary pressure isn't too high, but suddenly, the distal pulmonary arteries constrict, severely limiting blood flow through the lungs. This can be caused by patient agitation, or low oxygen saturation, or high CO2, or for no clear reason at all, and can occur without warning. This is the type of pulmonary hypertension this video is mostly about, as this is an acute issue that you will deal with in the ICU. What does it look like when a patient has a pulmonary hypertensive crisis? If they have corrected two-ventricle physiology, the blood can't flow through the lungs and thus can't get to the left side of the heart. Cardiac output and blood pressure will drop, and the heart rate will go up. If there is a central venous pressure tracing, this will go up. And if there isn't a place, like an open ASD, for blood to shunt right to left, they may not desaturate much. How about single ventricle physiology, or hearts that can freely shunt from right to left, such as a ventricular septal defect? Saturations will drop, and blood pressure will go up at first, as more blood is shunted systemically. Eventually, the hypoxemia will start hurting the myocardium, and the cardiac output will fall. In both types of hearts, end-tidal CO2 reading will decrease if this monitor is present. The risk for postoperative pulmonary hypertensive crisis is highest in the first postoperative night and goes down with time. Prevention is more important than treatment, and to prevent pulmonary hypertensive crisis in the cardiac ICU, it is helpful to know which patients are at risk. So let's talk about preoperative factors that will make your patient at higher risk for pulmonary hypertension postoperatively. Number 1, high pulmonary blood flow, meaning a left to right shunt. A normal heart will have a pulmonary flow to systemic flow ratio, abbreviated QP to QS, of 1:1. The same amount of blood is going to the lungs as to the body. With a large left to right shunt, such as with an atrial septal defect, this ratio rises as blood crosses the ASD to go to the lungs. This ratio can be 2:1, 3:1, or even higher. The higher the ratio before surgery, the higher the risk. Number 2, high pressure ejecting into the lungs. For this, let's compare the atrial septal defect we already looked at with a ventricular septal defect. Both have high pulmonary blood flow because of the left-right shunt, but for the ASD, blood is being pumped into the lungs by the right ventricle at low pressure. The VSD is pumping blood into the lungs from the left ventricle, which is much higher pressure because it is also pumping to the body, and thus at systemic pressure. Cyanosis, in combination with number 1 and number 2, make the risk of postoperative pulmonary hypertension even worse. So how can a patient have high pulmonary blood flow, but also cyanosis? Unrepaired transposition of the great arteries. Patients with TGA develop changes to the pulmonary vascular bed quickly, and this is one of the reasons we repair these patients as soon as possible. Number 3, high pulmonary vein back pressure. This can be from pulmonary vein stenosis, mitral valve stenosis, or poor left ventricular function with high diastolic pressures in the LV. These risk factors are additive, and the longer a patient has these before surgery, the higher their risk is after surgery for both pulmonary hypertensive crisis and permanently elevated pulmonary pressures. So a patient with an ASD, which only has high pulmonary blood flow, can live for years without risk of pulmonary hypertension. A patient with a VSD, which has both high pulmonary blood flow and high pressure, will develop pulmonary hypertension sooner. Number 4, genetics, especially trisomy 18 and trisomy 21. Patients with trisomy are at risk of developing pulmonary hypertension even without congenital heart disease, and those with heart disease will develop permanent vascular changes sooner than a non-trisomy patient with the same defect. Now that we know who is at risk, we can think of things we can do to prevent pulmonary hypertensive crisis, especially the first postoperative night in the cardiac ICU. Remember what can cause pulmonary hypertensive crisis? Oxygen is a pulmonary vasodilator, so even if the saturations are normal, keep oxygen flowing that first night. Hypercapnia, a high CO2, is a vasoconstrictor, so try and keep the CO2 normal and avoid respiratory acidosis. And agitation is bad, so adequate pain control and sedation.